So next up in your first aid book is the antianginal therapy. And by antianginal therapy, what exactly are we talking about? We mean the prevention of having chest pain in the future in someone that has had it before. Very important. You don't just start someone on antianginal therapy for no reason. You want to prevent it from occurring again. The reason that anginal episodes occur is very simple. Supply and demand. The heart is working too hard and demands more oxygen than it is receiving. We need to augment some of the factors that determine myocardial oxygen consumption. So I like to basically break it down into a couple of things. Number one, how much volume is actually in that chamber? That's the end diastolic volume. How much does that chamber want to contract or is able to contract independent of the volume that's within it? And that is the intrinsic contractility of the myocardium. Number three, what is our heart pushing or working against, which is the afterload, aka blood pressure. How fast is our heart trying to work, which is heart rate. So do not let this chart scare you. You do not have to even memorize it at all. We have discussed the physiology of the heart as a pump so well that you know what governs these variables. I'm going to try to discuss antianginal therapy in a way that will help you utilize the knowledge you learned, or I guess you should say relearned, in the physiology section. We just finished discussing how nitrates, right here, are mainly venodilators, and they do have some vasodilatory component of the arterioles, but a much greater effect on the venous versus the arteriolar vasodilation. They cause an overall drop in blood pressure due to an increase in the venous capacitance, so they can hold much more blood because we cause vasodilation of those veins. So blood will pool in the veins and therefore reduces the volume returned to the heart. It causes a decrease in the end diastolic volume because there's less blood in the chamber. And that is very evident by this down arrow. There will be less actin-myosin interactions because we're not stretching that ventricle as much because there's less volume in it, which means we need less ATP and also less oxygen, because you need oxygen to make ATP because ATP is required to reload all of the myosin heads that you used in the contraction. So the end result is that we reduce the myocardial oxygen demand. And we also decrease the ejection time because there's less blood within the chamber that's needed to be ejected. Giving someone with chest pain nitrates will activate the baroreceptor reflex because the stretch receptors in the carotid sinus and the aortic arch will sense that they are being stimulated less because there's a drop in the pressure. And this leads to the reflex sympathetic nervous response, which means that we get beta-adrenergic signaling to the heart, which increases our contractility and increases our heart rate. Again, we have a little bit of arteriolar vasodilation with our nitrates, in addition to venous dilation, so we cause a decrease in the overall blood pressure. We can directly counter this sympathetic response by giving them beta blockers, because the beta blocker will antagonize the beta 1 receptors that our reflex sympathetic response is trying to stimulate. Used individually, beta blockers will drop your contractility, but when used in combination with nitrates, you get little to no effect on the contractility because you cancel things out, and a decrease in the heart rate. The reason for the decrease in the heart rate when using combination therapy is that beta blockers have a greater effect on heart rate due to their ability to decrease the amount of cyclic AMP available. Remember that cyclic AMP opens those nucleotide-gated channels that cause the fronting current, which is responsible for the intrinsic depolarizations in the pacemaker cells of the heart. So the beta blocker is directly affecting the cyclic AMP, while nitrates are mostly affecting the preload and afterload, which are rather independent of heart rate. By decreasing the heart rate, we allow for a longer diastolic period, which allows greater perfusion of the coronary arteries, while also increasing the end diastolic volume of the left ventricle. That is elucidated here on the chart, where a beta blocker will decrease the heart rate, and therefore we increase the end diastolic volume because we have decreased contractility, because we decreased the beta-adrenergic component of our contractile systolic period. That means that we have a lot more blood left in that chamber, which is represented by an increase in end diastolic volume, and a decreased contractility and ability to push blood out of that left ventricle means we have a much longer ejection time. But what is beneficial is that because there's less cyclic AMP present within those myocardial myocytes, you will have less consumption of oxygen because there's less cyclic AMP around to activate protein kinase A, which will facilitate the release of calcium from the sarcoendoplasmic reticulum and flow of calcium through the L-type calcium channels, causing even more calcium-induced calcium release, which means that we decrease the amount of oxygen that myocardium needs, and that's very beneficial. With both of these components, we expect no effect or a slight decrease in the end diastolic volume because beta blockers raise it due to the accumulation of more blood because we have a less effective systolic period, combined with a decrease in the end diastolic period that you see with nitrates because they cause venous pooling and less return to the heart. Both of these target a decrease in the blood pressure, so you expect a combinatory decrease in blood pressure. The same thing with ejection time. Nitrates decrease ejection time while beta blockers increase ejection time. The two cancel each other out when given together and provide little to no effect. And the combination of the two is very beneficial because we greatly reduce the myocardial oxygen consumption. It is important to know that some beta blockers like pindolol or acebutolol are contraindicated. You cannot give them to anyone that's having chest pain because they actually act as agonists, which is something we do not want, considering that we're trying to prevent the myocardium from increasing its oxygen requirements because it's already oxygen deprived, hence they're having pain in their chest. Angina is a pain that is described as muscular pain. The heart is a muscle. It requires oxygen just like any other muscle. So when you're working out and you overstrain that bicep, it's like a burning pressure like pain. And that is the same way that these people present with the anginal pain because the heart is a muscle.